Alright, we are back for video 2. This is where we're going to start diving deep into each different kind of shock. So just a little outline here. We're going to look at the common physical exam findings, the imaging, hemodynamic monitoring, and the values you're going to see, pharmacologic treatments, ABGs, mechanical ventilation, specific concerns, and the effects of positive pressure ventilation, and then a little summary. So for the physical exam for hypovolemic shock, some common findings you're going to see are weakness, lightheadedness, and confusion. And then your signs and symptoms are going to be hypotension, tachycardia, oliguria, cool, clammy skin, and chest, abdominal, or back pain. In order to really effectively treat this one and even diagnose it, you've got to be able to determine what caused the injury that's got the patient to the point where they have internal bleeding or they're hemorrhaging. A late sign of shock is a cyanotic skin or a mottled appearance. And if the shock is non-hemorrhagic, then the decreased intravascular volume is due to the shifting of intravascular fluid instead of a lack of blood flowing through the body. So some imaging for hypovolemic shock. On the CT there, you can see the little arrow is pointing at the flattened inferior vena cava, and you'll also see some hyper enhancement of the adrenal glands. And then on this chest x-ray, there's some fluid present here in the corners, and you can also see that this hemidiaphragm on the patient's right side is a lot higher up than on the left side. And you can also see a little bit of vascular engorgement surrounding the hilar area. So then for hemodynamic monitoring, you're going to monitor hemodynamics for all different kinds of shock pretty much the same way. It's going to typically be through pulmonary artery catheter. Sometimes you can look through an A-line. And then some of the common values, your cardiac output for hypovolemic shock is going to be decreased, and your wedge pressure is also going to be decreased. So then for pharmacologic treatments, the big one for hypovolemic shock is fluid resuscitation, and that fluid is going to be chosen based on what fluid has been lost. So you could be replacing, or you could be doing fluid resuscitation with crystalloid solution. That could include saline, lactated ringers, or bicarbonate buffered saline. If it's being replaced with colloid-containing solutions, then it could be albumin, hyperonchotic starch, dextran, or gelatin. And then if it's being replaced with blood products or blood substitutes, it could be packed red blood cells, plasma. However, it's not recommended that you use vasopressors unless the hypotension is very severe and it is not responding to fluid resuscitation. And also something to note is that you want to monitor how much fluid you're giving them, because you can cause irreversible shock, or what they call over-resuscitation. And then ABG, the ABG for all of the different kinds of shock is going to look pretty similar as well. If it's a mild acidosis, so somewhere between 7.3 and 7.35 for the pH, then that's an early indicator that they could have shock. And the mild acidosis helps unload oxygen at the peripheral tissues, and it typically is not going to cause any change to their hemodynamics. And the only treatment we have for life-threatening acidemia, so under 7.2, is giving bicarb. However, this is not going to fix what caused them to go into shock in the first place. It's only going to help raise their pH so that their blood doesn't become too acidic to be life-sustaining. And then the hypovolemic patient will have a metabolic acidosis, and this signals that there's an underlying lack of adequate oxygen delivery, or there could be an increased oxygen consumption that the body cannot keep up with. This condition should be treated more aggressively than just administering bicarb, because the patient can go from bad to worse or even fatal very quickly. So then mechanical ventilation for hypovolemic shock. There wasn't much on it in the research that I did. Typically, it was just going to be giving high flow supplementary oxygen if needed, and ventilatory support if needed. So if they go into respiratory rest or they can't protect their airway, that might be a time to consider intubation and mechanical ventilation. But you're typically not going to initiate mechanical ventilation for hypovolemic shock, just because what's wrong isn't respiratory related. And then specific concerns for hypovolemic shock. You should avoid positive pressure ventilation because it can be detrimental to hypovolemic shock patients. You're adding a lot of pressure into the core area, and that's going to cause the hypovolemia and BP to worsen. However, it is noted that positioning the patient can impact their circulation in a positive way. So some of the examples given in the research was when you're giving the fluids to raise the patient's legs. You can also, if they're a pregnant patient and they are having problems with their BP being too low, you can turn them on their left side, and that relieves the weight of the baby on the circulatory system. And it is also noted that we previously recommended Trendelenburg position for hypovolemic shock, but it's not recommended anymore. The patient could be at risk of aspiration, and it can also worsen gas exchange instead of improving it. So that's it for this video. Just to review what we went over, we covered what a CT and a chest x-ray would look like for hypovolemic shock patients. We covered some of the typical signs and symptoms you're going to see with those patients. We covered what you're going to monitor hemodynamically wise, what pharmacologic treatments you can give, what you can expect from their ABG, what we recommend in terms of mechanical ventilation, and also why we would not use positive pressure ventilation.